Welcome to the New Canaan Library and to the third in our 2014 fall series of Med Ed with Stanford Hospital and the New Canaan Chamber of Commerce. We welcome back New Canaan's own Dr. Dina Ebright of Fairfield Primary Care and Stanford Hospital to moderate this evening's program. We are very pleased to have Dr. Catherine Sandu with us tonight to discuss health below the belt. We thank you, our patrons, for your continued support of the New Canaan Library, which allows us to offer this caliber of programming. Dr. Ebright?
Thank you, Jocelyn. As Jocelyn mentioned, this is our third in the Med Ed lecture series. For those that haven't been here yet, my name is Dina Ebright. I'm a general internist, and I recently joined Fairfield County Primary Care, which is a Stanford Hospital practice here in New Canaan on Grove Street. Again, I want to extend special thanks to the ladies in the back, Donna and Maria from Physician Relations, and to Jocelyn with the library, and to Tucker Murphy from the Chamber of Commerce for collaborating with us and helping to make Med Ed possible. Before I introduce our speaker, I'll just call your attention to the note cards, index cards, and evaluations on the seats. If you have questions that come up, feel free to write them down. We'll collect them at the end when we do our question and answer session. And please give us honest feedback on the evaluations. So now let me introduce you to our physician speaker for tonight, Dr. Catherine Sandu, who will be talking about health below the belt, a discussion on female pelvic health. Dr. Sandu is board certified in both obstetrics and gynecology and female pelvic medicine and reconstructive surgery. She's been practicing in Stanford in the area since 2009 and joined one of Stanford Hospital's practices in February of 2013. She has several publications in the field of urogynecology and has presented on different topics over the last several years at the American Urogynecologic Society meeting. Dr. Sandu?
Thank you so much for coming tonight. My name is Kathy Sandu, and like Dina mentioned, I'm a urogynecologist in the area. I just want to talk a little bit about what urogynecology is and what I do. It is a subspecialty of obstetrics and gynecology, but can also be a subspecialty of urology. It has recently been board certified as a specialty, and it's only been board certified for about a year now, which means that a lot of physicians don't even know that we really exist. And so I gather that many of you don't really understand what a urogynecologist is or does. So that's part of the intent today. So I'm going to talk about health below the belt. I want to talk about female pelvic health as it relates to conditions of the pelvic floor, treatment options. I want to talk about some female pelvic anatomy. For those men out there, this topic is important because you have women who are spouses, sisters, cousins, daughters, mothers, and these are very common and very important health issues that women face. So today's objectives, we're going to talk a little bit about female pelvic anatomy. This is a medical education series after all, so we're going to get a little bit technical, hopefully not too boring. I do want to talk about some of the common pelvic conditions that women face and have, and some of the treatment options that are available. And then we'll briefly discuss some prevention. So pelvic health in general is uncomfortable. Nobody likes to talk about it. It's a little embarrassing. What I do is not typically good, dinner party conversation. It's hard to talk about, urinary and fecal incontinence nicely at the table. It's hard to talk about some of the surgeries that I do. But tonight I just want to dispel all of that. I think we really need to start talking about it. We talk about mammograms like it's not a big deal, and that's breasts. So we should be able to talk about pelvic health like any other condition. It's, embarrassing for a lot of women, but it's very common. So 1 in 3 women, they say, will deal with some pelvic health condition. They're common conditions, but they're not normal, and they are very treatable. So it's important that we understand them. So let's talk a little bit about female pelvic anatomy. I hope that this translates. So this is a picture of the organs that are found in the pelvis. So you see the bladder, the uterus, and the rectum. Let me use the pointer here, does it? Okay, so here's the bladder, here's the uterus, here's the rectum. This is a picture of a woman looking this way. So she's facing this way. This is the pubic bone. So if you push down, you can actually push on your pubic bone right now. It's low down, below the belt, but that's the bone. Right behind it is the bladder. Right behind that is the uterus that comes down into the cervix. This is what dilates when women have a baby to 10 centimeters, and the baby either comes out via C-section or out the vaginal canal. And then this is the rectum. And these are the intestines. This is the colon that will then lead to the small intestines and up to the stomach. There are 3 openings in a woman. There's the urethra, which is the tube where the urine comes out that leads to the bladder. There's the vagina that leads to the cervix and the uterus. And then there's the rectum, which leads to the intestines. So those are important landmarks. You do have fallopian tubes and ovaries as well, but these are really the important structures that we're going to discuss. Here's a similar picture where, again, we see the pubic bone. Here's the bladder and the urethra. Here's that uterus with the cervix and the vagina. And here's the rectum. Now, interestingly, they stay put. They stay in the right place because of the ligaments, tissues, and muscles that surround them. So those are very important to understand, because when things aren't normal and those tissues and muscles are weak, that's when we start having some issues. So in this picture, we see some of the connective tissue that's important. Now, connective tissue is a general word that a lot of doctors like to use. It's very general. It doesn't really mean much. For us, this is the connective tissue that supports part of the bladder and the urethra, the white band that you see here. The white band comes up around the uterus, and then it comes down in between the rectum and the vagina. They've got all sorts of fancy names. You can call them a bunch of different things. And actually, it's very confusing because if you look up a textbook, it actually will have a different name in 5 different textbooks you look at, and it took me several years to figure out that they were all talking about the same thing. Because it's not always very clear. One of the things that always bothered me about pelvic anatomy is that we have an entire year of anatomy in the first year of medical school, and there was only half a day devoted to female anatomy. And that always bothered me a lot. There was 3 days on male anatomy, half a day on female anatomy, and then I became an obstetrician and gynecologist and had no idea what I was looking at. So I had to relearn everything a second time. So I digress. Let's go back. So here are the connective tissue. This is the connective tissue we're looking at. Again, fancy terminology. This connective tissue is called fascia. Fascia is found all over the body. It keeps things nice and strong. It's shiny, it's white, it's thin, but it is strong. It is very, very strong, and it keeps things in the right place. It's just called fascia. In the pelvis, it's called endopelvic fascia. Now, if we want to get all technical, we can call it something else depending on where we find it. So here we say, oh, this must be pubocervical fascia, and this must be rectovaginal fascia because it's between the rectum and the vagina, and this is by the pubic bone and the cervix. And then when we get up around the cervix, it's the pericervical fascial ring. But it's just tissue, and it's strong tissue, and it keeps things in place. That's it. So now we start getting fancy. Here is what I like to call a pelvic bowl. This is a bowl. This is looking into the body. So this is as though somebody's torso was cut right in the middle, and you look inside, directly inside. I hope that's clear. You see so all of the organs are actually here. They've been transected. They've been cut away. So all you see is the holes that are left over. So you see the urethra. This is the pubic bone. So this is the front of the patient. This is the front of the woman. This is the front of the sister, mother, daughter, cousin, aunt, right here. This is the pubic bone. This is the urethra. This is the vagina. This is the rectum. Those are the 3 openings that have been cut away. This white stuff that you see here, again, some of that fascia that we were talking about. But there's also there's a lot of musculature, a lot of muscles in the area that keep those organs in place as well. And they have super fancy names, and those names actually relate to where they exist in the pelvis. These three asterisks correspond to the three big muscles in the pelvic bowl, and we call those muscles the levator ani muscles. So in case you hear that, that's where that is. Here's my technical part of the presentation. All right. So you have the pubococcygeus, by the pubic bone around to this area. You have the puborectalis from the pubic bone around the rectum, and the iliococcygeus from the ilium down through to the coccyx, which is your tailbone. And then the coccygeus muscle, another muscle. So these three muscles make up the levator ani muscles, and then the fourth makes up the whole bowl that we discussed, the pelvic diaphragm, the whole, and this is what we're going to come back to when we talk about some of the problems that exist. That's why I'm showing it to you. Where all of these muscles come together, we see these white lines, and once again, that's a fascial white line. That's that strong tissue as an extension of the muscles that exist, and that holds these muscles in place from one side and a bowl to the other. So when we talk about some of the problems, again, try and keep this bowl in mind. I'm not going to this is the last crazy anatomical slide, but I do want to point it out because I think that everybody in the audience should be familiar with some normal female anatomy. Now, this is looking at a patient, at a woman, as though she were at the gynecologist's office in stirrups. It's sort of the position many women deliver a baby in. Is there another way to project that? I think that's probably pretty clear for most of you. Hopefully most of the women have seen a gynecologist, and hopefully the men sort of understand what that is, but it's important that we know what's down there. So here's that urethra, again, that opening that leads to the bladder. Here's the vagina. Look how close it is. These are the labia on each side. When you open the labia, and you just spread the labia from side to side. I'm going to use a lot of words, by the way, that sound a little bit embarrassing. You might want to chuckle. You can, but I'm just going to use them very freely like I would anywhere else. Okay, so these are the labia here on each side, and when you spread them, you see the urethra and the vagina. Look at how close they are in proximity to one another. So some of the problems that can arise, like recurrent urinary infections, for example, can come because of the bacteria from the vagina that creeps right into that urethra. And here's that third opening, the rectum. You see a lot of muscles around the rectum. You see muscles on the sides here. This is the perineum. This is the space between the vagina and the rectum. This is an important space. People talk about the perineum. A lot of people don't really know what that means, or the perineal body. Well, let me make it very clear. It's the space between the bottom part of the vagina. We call that the fourchette for anybody who cares. This is the posterior fourchette of the vagina, and the rectum. This space, this grouping of muscles, which by the way are many muscles. There's this muscle here, the transverse perineal muscle. There's the external ani muscles here. There's the bulbocavernosus. Okay, so there are a lot of muscles that make up the perineal body right here. And by the way, this is that bowl I was telling you about, but this is looking at it from the other angle. Hopefully that's clear, and I think that's the most that we have to take away from this picture. All right, so let's get right into the conditions and treatments that we want to talk about. Here's the first topic, urinary incontinence. Again, we just have to be very, very open with ourselves, clear this doesn't just happen in women, men, it happens in men as well. We're not going to talk so much about the male factors, but it's important to talk about what happens with women. I also love this one, urology department, can you hold? I think it's hysterical. All right, so why do we care about urinary incontinence? It's not life-threatening. There are other more important conditions in women, right? There's heart disease, there's cancer. But I'm going to really plug this now. This is what I do, after all. It's not life-threatening, but it is life-altering. It's extremely common. It has a very, very significant impact on a woman's life. And actually, healthcare expenditures for this condition are extremely high. So we can look at it from a number of different perspectives. Let's talk about the prevalence or how common overactive bladder is in comparison to some of the other chronic conditions you know about. I don't know if this slide translates quite as well, and I don't want to dwell on it, but let's just look. You see sinusitis, many of you have had that, arthritis, heart conditions, and then overactive bladder. Overactive bladder is only one type of urinary complaint that women can have. One out of several. And look at where it falls. Fourth out of the millions of Americans that have it. It's not so far behind heart conditions, arthritis, and even chronic sinusitis. I mean, this is millions of Americans, so I get it, but just look at it. It's above asthma. It's above osteoporosis, diabetes, Alzheimer's. So it's up there. Now let's talk about the impact that this has on a quality of life. So I have a lot of women that come to the office and they have 10 different conditions that they're being treated for. But guess what? It's the urinary incontinence they can't handle. They can't handle it because it's impacting their life so significantly that they can't even tackle some of the other aspects of their lives. So let's talk about why that might happen. You can see all of the ways in which this can impact quality of life. I've had young nurses in my office who've, they've dropped out of nursing school because they're constantly racing to the bathroom. I've had teachers who've had trouble teaching. I've had women who have stopped going out and having lunch with their friends because they're constantly needing to use the bathroom. They feel embarrassed. I've had younger women who feel like they smell all the time, so they can't sit next to a coworker. And it's common. It's happening. This happens to women. So there is just tremendous, tremendous impact all the way around. There's a lot of psychological impact. Women feel depressed, guilty. They don't feel good about themselves. They feel old. It only happens to old people. Urinary incontinence is an old condition. You only have it if you're old. Well, if you could just be a fly on the wall in my office, you would see that, that 28-year-old, that 30-year-old, and that 15-year-old are in the same boat. So there are a lot of factors here. And then this is just a quick slide on expenditures. So we see urinary incontinence, osteoporosis, and breast cancer. And check out the expenditures for urinary incontinence. So it's up there. Some quick facts that I think are interesting when we're talking about this. So we talked about how 1 in 3 women have a pelvic floor condition. Well, let's talk a little bit more specifically. There's a type of incontinence, which we're going to discuss, called stress incontinence. 1 in 3 women have it within 5 years of a vaginal delivery. So people talk about, oh, you have a vaginal delivery, and let's talk about the difficulties of breastfeeding and how hard it is to attach and bond with your baby and blah, blah, blah. But let's talk about other things that might be happening as a consequence of having maybe a difficult vaginal delivery or even just being pregnant. So more than 50% of women who have incontinence, they're not talking about it. They're not telling their physician. And half of those women are waiting 4 years before they're even mentioning it to any healthcare provider. We know that women in nursing facilities have a tremendous amount of incontinence, and this is a fact that always baffles me. In the US, more feminine pads are used for incontinence than for menstruation. So these are some of the familiar phrases I hear in my office. I laugh so hard, I ... I actually have, my husband got me a sign that I put in my office that it says, I laughed so hard, tears ran down my leg. I love that. I love that sign. But they made a sign in a home store about that in my town. Like, that's how common it is. So I enjoyed it for many reasons. So, people say, I never know when I'm going to leak. I always wear pads no matter where I go. I know where all the bathrooms are. There's the telltale sign, right? The woman that knows where the bathrooms are at Stop, she knows that the bathrooms at Stop and Shop are cleaner than the ones at A&P. She knows that that's when you know it's it's starting to take over your life a little bit, and maybe you can have that addressed because it can be treated. Women say, I avoid having accidents by making sure I don't drink too much water. This is a big one. Women are becoming dehydrated. No one wants to drink water because no one wants to race to the bathroom. And then I see women who want to exercise, but when they do, they leak, so nobody wants to exercise, so people are stopping a lot of their activities. So a lot of these women report leaking when they're laughing, sneezing, jumping, lifting. They might feel like they have a sudden and immediate urge to urinate, and they avoid embarrassment a number of ways. So they avoid exercise, they know where the bathrooms are, they're wearing pads all the time. A lot of them wear light-colored clothing, or they carry an extra change of clothes in case of accidents, and they avoid getting too close to people. And they miss a lot of important events in life because of it. So let's get right down to it. There are 4 types of incontinence in women. In men, there are also many of these types of incontinence. I would stress that in men, urgency incontinence, that second one, which is overactive bladder, is probably more common as a result of prostate surgery that can happen. I might talk a little bit about that. I don't treat men, but that is... I'm sleeping. It's okay, I'm sleeping. I'll get back. Okay. So I might need help. Is there a... It's all right. I need a doctor of the computer. It didn't want to hear that. Does this need to be plugged into something? Am I out of battery?
No, because you're plugged in.
Actually, it looks like it's
Power
asleep.
went off.
Hold on. I feel like it might not be.
Getting power, yeah. Yeah, have you plugged into the...
I think I'm going to continue talking, if that's okay. So the 4 types of incontinence that I want to talk about: stress urinary incontinence, urgency incontinence, mixed incontinence, and then there are some other types of incontinence that I will also mention. So stress incontinence is the typical leaking of urine while laughing, coughing, sneezing, Zumba, jumping jacks, lifting a small child, if a lot of healthcare providers who are lifting patients, any pressure that's put on the pelvic floor. You got that going a little bit, that's good. Okay. Let's just see if this will come back to us in a few seconds, and then we'll. A handsome crowd. I know. Okay, good. That's fine. Yay! Okay, perfect. I'll just make sure to keep my finger on the button. So let's talk about that stress incontinence. So it's involuntary leakage. Like we said, coughing, laughing, sneezing, lifting, exercising. You know, the woman that can't play tennis because she leaks during tennis. It might just be one activity that really seems to make a difference because it's the one that that particular woman does a fair amount of. So what's really happening? It's those muscles, those tissues that support the bladder and urethra that become damaged and weakened. So now that urethra that's really held together and in place by the muscles and tissues under it is no longer supported. And when you cough and sneeze and exert yourself, the urethra moves. It's that movement that causes the leak because it takes you out of the position that the urethra should be in. So here's that picture of that woman again, looking this way. Here's that pubic bone again. Here's that bladder, the uterus, and the rectum. And here is that wobbly urethra. And I don't know if you can see this, but there's light blue leaks. So that's this tissue here, this fascia, these muscles, the periurethra, the muscles by the urethra, and that fascia there that's no longer supported. And why does that happen? It's any pressure that's put on the pelvic floor for a long period of time. So pregnancy alone will do it, obesity will do it, just being 9 months pregnant with pressure on the pelvic floor. If you have a child, vaginal delivery will additionally damage the floors of the vagina, and aging, because menopause causes decreased estrogen. And what people don't talk about with decreased estrogen is that there are estrogen receptors all over your body. So people have started talking about perhaps Alzheimer's being correlated with low estrogen, you know, the hot flashes, the mood swings, the lability, there's so many, the bone density that's lost, all these things that you lose when you lose estrogen, but nobody talks about the fact that you also lose the integrity and the strength of your pelvis and all the muscles in that area. So if you didn't experience it when you had a pregnancy or you had a delivery, it'll hitch up when you're in menopause. So there are other causes for sure. So obesity we talked about, but you can be very, very trim, very thin, and be a marathon runner and be pounding that pavement for many hours a day, and that can also affect the pelvic floor. So any chronic heavy lifting or straining, whether that's done in the work environment or at home. Certainly smoking, because it decreases the integrity of the muscle. The muscle becomes weakened. You lose tissue strength with smoking. Radiation will do the same thing. Obviously, if there's been trauma in that area. And we also understand that these are genetic in some fashion, because your tissue integrity, how strong your tissues and muscles are, is genetic as well. So what's the treatment for this problem? So the goal is to strengthen or help out those pelvic muscles that have been damaged. That's what we want to do. That's the goal. There are only two options for stress incontinence. There's pelvic floor exercises, which I'll just discuss briefly, and there's surgery. There's no medication available in the United States for stress urinary incontinence. Doesn't exist for this condition. Pelvic floor exercises, what are we trying to do when we do Kegel exercise? You guys have probably heard about Kegel exercises forever. Kegel exercises are strengthening the muscles of that bowl, those levator ani muscles, those muscles with those long words. That's what it's trying to strengthen. And by strengthening those muscles, you're strengthening the muscles around the urethra. So a good Kegel exercise is done not in the bathroom, when you are trying to stop the flow of urine. That should not be done in the bathroom. You can identify the muscle group in the bathroom, but those exercises should be done out of the bathroom by squeezing for 10 seconds and relaxing for 10 times in the morning and 10 times at night. That's a proper Kegel exercise. If the Kegel exercises aren't working well, you're not sure whether you're doing them properly, you can do the super Kegel exercises, I call them, by doing some pelvic floor physical therapy. And in doing this, there's a probe that's in the vagina, it's attached to a computer, and we can actually see how good your Kegel muscle is, and we can electrically stimulate that area to cause some strengthening of the pelvic floor muscles, and that's part of biofeedback. So that's pretty much all you have that's non-surgical. And the rest is surgical, but thank goodness we've got something terrific for this. So back in the day, surgery for stress incontinence was incredibly invasive. It was very complicated. People felt like they spent forever in the hospital. There was a 6-week recovery. It wasn't necessarily permanent. This issue would be recurrent. And now we have a soft mesh sling. So this sling is a ribbon. It's a ribbon of mesh that's placed under the urethra. It's placed without any tension at all, just sits there. It just sits right under the urethra where those muscles were weak. And your muscles grow into it. So that's how it gives you some nice, good support. And that's how it controls leakage during these sudden movements so that the urethra can actually stay put. It's a quick procedure, takes about 15 minutes in an ambulatory type setting. It's done with tiny incisions. It's done either with local anesthesia, a little bit of sedation like a colonoscopy, and you go home pretty quickly. So again, a little chuckle in the audience perhaps. This is my husband saw it. He was like so devastated when he saw this picture at home, but this is what we're talking about here. So this sling just sits from this side. This is the obturator space. This is where some muscles come out, and you can see the muscles have been taken away, and you see that area here, and it just sits like a U, just like a U right under the urethra. There's the urethra. There's the vagina. Of course, it's underneath the tissue, so you don't see it, but that's what we're talking about. Okay, I seem to be frozen. Here we go. Okay, so patients go home the same day. They return to their normal activities pretty quickly. They feel pretty good in a few days. We tell them don't do Zumba for 2 weeks, but after that, go right ahead. And it's very effective. I mean, the studies that we have say that more than 90% of women are completely dry over about a 15-year period. It's all the data we have, but it's pretty good. Now, I just want to say a quick thing about this quote-unquote mesh. The FDA came out with a warning against the use of mesh, vaginal mesh, in 2008 and 2011. The FDA had some concerns regarding vaginal mesh. They are not talking about this sling. This sling has been properly studied. It's the reason why the FDA allowed other vaginal mesh products into the picture, was based on these good studies. And then they realized that there were other mesh products that may perhaps have some, that may be concerning for women. And we might touch on that in a little bit. But I just want to be very clear that this has been properly studied and effective. So let's go on to another type of incontinence, which is urgency incontinence. And I want to get back to a little bit of anatomy and physiology. So for the men out there, this includes you, and for the women, listen up. This is how your normal bladder works. Here's your bladder muscle. It's called the detrusor. This muscle holds urine, and when you want to go to the bathroom, it's pretty simple. This muscle contracts, and the urethra opens. That's how you go to the bathroom. But there's a whole pathway, and a whole pathway that happens sort of reflexively, that can be interrupted, changed, or damaged. So normal voiding function depends on both voluntary and involuntary control. So you can try and hold it when you have an urge to go to the bathroom, but you can't stop the process once it starts. So let's say something else is in control, perhaps your bladder and not you. And when that bladder starts that process of going to the bathroom and has sent that signal up to your brain, and it's coming down your spinal cord and it's contracting the bladder, it's really hard to stop. So there can be disruptions along that pathway that make it difficult for you to control going to the bathroom. So this is also fancy. And we don't have to, dwell too much on here, but this is what I was saying. So here's the bladder, and it sends signals up nerves, and they go up to the brain and the spinal cord, and then it comes back down, and then it sends more signals down other nerves, and then you get a contraction and a relaxation, and you go to the bathroom. That's what we're talking about. The bladder's like a balloon. It distends, it gets bigger like a balloon, which means the pressures stay the same. You can blow up a balloon, the pressure stays the same, but at some point, that's it, and the balloon pops. Your bladder doesn't usually pop, but what happens is you leak, sometimes if it gets too big. So this is just a little schematic of what's normal. Here's just a normal bladder and a urethra, and this is when it contracts and the urethra opens. This is how you go to the bathroom. And this is how you store. This is the bladder getting bigger and the urethra clamping down. Now, normal storage is a sympathetic response. So what's sympathetic? It's that flight or fight response, and I don't know whether anybody has talked about this before. They talk a lot about this in medical school, and the example they always use is, say you're being chased by a bear. And so you're running and you're being chased by a bear and the adrenaline's going, and that's the sympathetic response. You don't want to have to go to the bathroom during that you don't want to have to. You don't want to have to, have a bowel movement, and you certainly don't want to have to urinate when you're running away from the bear. So all the blood flow and all that adrenaline is going to the important parts of the body. The heart, pump that blood, get away from the bear. Don't go to the colon, don't go to the bladder. So that's what happens when you store urine. It's a sympathetic response. It's that same fight or flight. Here, when you want to go to the bathroom, that's the parasympathetic. That's the other part of the nervous system where the bladder contracts and the urethra relaxes. And I'm just going to mention, I don't know if this is too much, but I'm going to go for it. So here are a few of the sort of receptors that are involved in that. So when the bladder contracts, it contracts because there's a neurotransmitter called acetylcholine. And the acetylcholine, by the A's, is stimulated. It's activated, and that's how it contracts. And then this alpha is an alpha agonist, and that usually clamps down on the urethra. So when you don't have it clamped down, it opens. When it stores, you want to prevent the acetylcholine from contracting the bladder and instead activate this one, a beta-2 agonist. This might be a little much, but the beta is sympathetic and the acetylcholine is parasympathetic. The acetylcholine is what makes you go and what makes you contract. And the only reason I mention this is because treatment sort of depends on this. So what's really going on when somebody has urgency incontinence, that gotta go right now? So that normal voiding process, that normal reflex, we call it the micturition reflex, it's interrupted in some way. And the bladder ends up having these involuntary spasms or contractions that give you the urge to go when you're not ready to. So now the bladder gives the signal up to your brain that you have to go. You may not have a lot of urine in there. It also may not be socially appropriate for you to go. So those are two conditions in which you're going and you really don't want to. And the symptoms that we see are, you know, the frequency, the urgency, the gotta go right now, those commercials, the waking up at night, going, you know, 2, 3, 4 times at night, the leaking before you get there. You actually don't have to leak in order to have this condition. You can just go a lot to the bathroom. You can just wake up at night, or you could just have sort of that urge where you can't wait in line at the mall. And the most common type of urgency incontinence is an overactive bladder. That might be something that you've heard, an overactive bladder. So again, that reflex is changed, it's altered. And we think it's because there's that signal to the brain that's increased. And we also think that around the bladder, there might be some pathways that make it contract and have some spasms. You do want to rule out other causes, and that's why you want to see a specialist. You want to make sure that you're not having recurrent infections, that there aren't any stones, masses, polyps, anything that's going to irritate your bladder and make it contract or spasm. For those men out there, the outlet obstruction refers to the prostate, preventing the outflow of urine, and that can make for an overactive bladder. In a similar way for females, if you have prolapse or your bladder falling down or the rectum falling down, which we'll briefly discuss, you can have that same phenomenon where it's just difficult to empty out your bladder. There's many metabolic factors that make you go to the bathroom frequently. Waking up at night, uncontrolled diabetes is a big one. Drinking a lot of water or fluids is another one. And there are several medications that we know that can cause you to go to the bathroom urgently and frequently. If you're, if you're taking a water pill or you're taking a, certain blood pressure medications, certain diuretics, even some medications for pain can make it difficult for you to go to the bathroom, and you're always storing a lot of urine, which can make you feel like you're going to the bathroom all the time. Certainly if you're pregnant or you have psychological factors, that also plays a role. So there are things we want to rule out, but the majority of women have an overactive bladder, which is just happens. Again, treatment. The goal is to change the signaling to or from the brain. So here we're left with pelvic floor exercises, medications this time, and different kinds of surgical procedures. So the pelvic floor exercises, those Kegel exercises do two things. One is that they strengthen the muscle so that when you have an urge to go, you can hold it, but it also sends the signal to the brain to just quiet it down. That's what it does. We know that it sends those signals to the brain. So that's one of the things that we can do. So now we're seeing two ways in which pelvic floor exercises might be beneficial. Just as an aside, those pelvic floor exercises are only about 50-50 that they'll help, and you do have to do them. It requires tremendous commitment. You're looking to do them forever. Like conditioning any muscle group, or you go to the gym to exercise, you have to keep working those muscles in order for them to work. And then we have medicines and some surgical procedures. So what do the medicines do? They actually relax the bladder so that it can hold more urine. We want to prevent the spasms, we want to prevent the contractions, we just want to hold better. There are some side effects to some of the medicines, and the two biggest ones are dry mouth and constipation. So the most common medicines are what's called anticholinergics. Guess what this does? It blocks that acetylcholine. It blocks that ability for it to contract so that it can just relax and hold better. And I just put the brand names because you may have seen commercials for some of these, or you may know them yourself, like Vesicare, those little iron bodies that walk around. I think I saw recently one for Detrol. I think Oxytrol patch is now over the counter. Azo now has a homeopathic type of remedy for urgency incontinence. So there's a lot of commercials out there. And now we have a new medicine for the bladder, which is Myrbetriq, which focuses on the storage mechanism rather than preventing the contraction. So let's say those don't work, or let's say you have side effects, or let's say you can't take them for a number of different reasons. So then we go to some of these minor surgical interventions. So this is a woman. She's reading a book, she's hanging out, and she's sitting in the office, and she's getting a little acupuncture needle that's placed just above her ankle, and she's grounded, so she's sending a little electrical stimulation up through this nerve, which connects to this nerve, which then connects to the nerve in the bladder. And she hangs out for about 20 minutes and gets a little bit of electrical stimulation. And then she comes weekly for about 12 sessions. And in about 8 to 10 weeks, she may have improvement in symptoms. That's one option. And that electrical stimulation, we actually don't really know how it works. So I really, if somebody tries to tell you that they know how it works, they really don't. But we have a lot of theories. So, I can tell you some of the theories. So inner stim is a little bit more electrical stimulation, and it's thought to block or mask those inappropriate signals from the bladder. So all those signals that go up to the brain that tell the brain to go ahead and contract the bladder, it blocks them. This is an electrical stimulation that's a little bit more involved, and so we test it first. So people just don't get an interstim implanted. An interstim is a little pacemaker, and it sits in your lower back, upper bottom, and it paces the bladder. But we test it first. So we have a patient either come to the office or in the operating room, and we place a little wire right here. This is the sacrum. This is the coccyx, that tailbone. And this is the S3 foramen. We spread a little wire here. This is where the nerves are to the bladder. And it's connected to an external device. So for a few days, a woman wears a little device on her hip, on her pants, and she can electrically stimulate the bladder this way to see if her symptoms improve, to see if that signal to the brain changes. And if it does, then she goes back to the operating room, and instead of that coming out of her body, it's just all connected inside, right under the skin in their lower back, upper bottom with a little pacemaker. And that's a permanent procedure. The other thing we have is Botox in the bladder. So, I get this a lot. So I inject a lot of Botox in the bladder, and a woman will say, can you give me a little here, a little here? I'm not there yet, but I might, because I really get it a lot. So Botox in the bladder. Botox has been used all over the body. It's used for eye conditions like strabismus. It's used for excess sweating. It's used for migraines. We see Botox now everywhere, and the bladder is no exception. So what Botox does is it paralyzes the muscles, and in the bladder, it relaxes them. It just paralyzes them. It relaxes them to prevent spasms and to store better. And so how does it work? It works through that acetylcholine again. It blocks it so that it just relaxes the bladder. This is a picture of your bladder. This is the inside of the bladder through a little cystoscope. And these are just these little tiny injections that are placed in the bladder. Mixed incontinence is the most common form of incontinence. It's stress and urge together. That's pretty much it. And the only thing I'll say about this is that those are two conditions. So women that come in and they say, I'm leaking with coughing and sneezing and I'm racing to the bathroom, actually have two conditions, not one, and they're typically addressed separately. Some women don't necessarily realize that. They think it might be just one condition. And then we have other types of incontinence, like leaking all the time, feeling like they're never really completely empty when they go to the bathroom. And that just might be somebody who doesn't have good sensation to the bladder, a diabetic, for example, who has poor nerves going to the bladder, doesn't feel that their bladder's getting full, and is unable to empty completely. Functional incontinence, you just can't make it to the bathroom. You had a knee replacement. It takes you 20 minutes to get there. You can't make it. That is real. It's called functional incontinence. And so those are things to also keep in mind. Transient incontinence is things that happen with medical problems like a urinary infection. In fact, that's one of the most common reasons why women have incontinence. They just have a little bacteria in the bladder. Let's go on to another common condition, pelvic organ prolapse. We're getting there, guys. We have about 10 minutes left. We can push through. All right, so here are some of the familiar phrases that I hear for pelvic organ prolapse. I feel a bulge. I have a sense of pressure, something's heavy, something's out of place. I can't seem to have a normal bowel movement. I can't seem to control things. I'm uncomfortable with sex. I don't feel like my normal self. I hear these vague symptoms. So pelvic prolapse is a condition that affects many, many women. It increases with age. Half of women who have given birth vaginally have some degree of prolapse. They may not be symptomatic, they may not have symptoms, but if they all went to the gynecologist and had it assessed, they would have it. 40% of women over 40 have this condition. So just other statistics. So more than 30 million US women over the age of 45 suffer from prolapse. 1 out of every 2 women, so we talked about this, 40% of women over 40, 50% of women over the age of 45 suffer from some type of prolapse. But guess what? Only 15% of women are seeking treatment. So what is happening? That bowl, those muscles, that hold all those organs in place, they're weakening. And what it does, it creates a hernia. It's just like a hernia in any other part of your body. Many of you have probably had hernia repairs. Those weak weak tissues that allow for an organ to push through. It's exactly what's happening, except in the vagina. And as a result, whatever organ is in the vicinity is going to push down, and you feel it like a bulge. So here's that bowl again. These are the muscles we're talking about. These weaken, and they can tear. They can tear away from that fascial line and cause the bladder to drop in. They can tear in the middle. They can tear in the back. They can tear anywhere. And these are the things that can fall. The bladder can fall down, the top of the vagina, the rectum, the intestines, the uterus. And these are the fancy names that go along with them. So a cystocele, which you may have heard, is when the bladder falls in the vagina. A rectocele is when the rectum falls in the vagina. Uterine prolapse is pretty self-explanatory. An enterocele is when small bowel falls into the vagina. And then the top of the vagina can fall down as well. Here's a picture. So here is that patient facing this way again. Here's her pubic bone. Here's the bladder, uterus, rectum. Here's the bladder falling down. Remember I showed you that fascia, that really strong stuff that was in between? That's where the muscles are as well. When that weakens, this is going to plop, fall right in, and they feel it as a bulge in the vagina right here. In a similar fashion, but posteriorly in the back wall, you can have the rectum pushing into the vagina from weak fascia in between the vagina and the rectum, or weak muscles in that area. And here's the vaginal vault coming down. This is somebody whose uterus was removed and the top of the vagina is falling down, but this could similarly be the uterus or the cervix. So what is the treatment goal here? It's to restore the organs to the normal position. We want to get them back where they need to go. The problem is that we have to compensate for defects that we can't really control. We can't put them back where they were before. We have to attach them to different ligaments that are strong because their muscles and tissues are weak. So you can try and strengthen the pelvic floor by doing Kegel exercises, pelvic floor physical therapy. Not terribly effective when it comes to prolapse. Once the prolapse is there, it's typically not treated well with Kegel exercises. But you can support it, and you can support it non-surgically by placing something called a pessary, or you can do surgery. That's pretty much it. Here's a picture of the most common pessary that we use. It's called a ring pessary with support. This looks like an old diaphragm that women used for birth control. So any of you that used a diaphragm, any men that saw a diaphragm, it's very similar. And this goes inside the patient to support the part that's falling down. It just lifts it right up. Now the problem with it is not a great treatment option, but it'll make somebody feel better. So if you're not a surgical candidate or you're nervous about surgery, then this is a great, or you're not even sure if your prolapse is giving you the symptoms, this is great because you put this in and then you know you feel better, then you know that surgery would work for you. Or maybe you like the way that it feels and everything's back in the right place, but you're not treating the actual problem. Look how many pessaries we have, tons. The most common is the ring with support and the Gellhorn here. Those are the two most common ones, but there's plenty out there. So surgical treatments for pelvic prolapse have also evolved. It's not a perfect science. So the sling that we have for stress incontinence, fabulous. What we have for pelvic organ prolapse is not yet 100%. It's why we have so much out there. So if you can see what we have now, we have a lot of minimally invasive techniques. So we can either approach something vaginally or abdominally. So vaginal surgery, what people don't realize, is actually less invasive than laparoscopic surgery or even robotic surgery, but not everybody is a candidate for the vaginal approach. So then we can go up laparoscopically or robotically and pull everything that's falling down up. And then we talked about vaginal surgery. So that is what we're dealing with. And this is just a picture of some of the things that we would do. So we're looking in the bowl, directly inside the patient, but this is actually approached vaginally. We can attach the back wall of the vagina, for example, to ligaments by the vagina. These are strong, so this will pull the vagina to either end and it will hold it back up. Or if you're abdominal or laparoscopic, you can place a Y-shaped graft around the vagina and pull it up, pull it up, pull it up, pull it up to ligaments by the sacrum. And that'll just hold the vagina, see how it's nicely held. It now strengthens the tissues and muscles around the vagina so nothing can push through, nothing can herniate. And just once again, prolapse surgery continues to evolve. There were some complications with transvaginal mesh that was placed for several years. And like I said before, the FDA came out with a warning against the vaginal mesh. What I showed you before here is abdominal mesh. This has been around for 60 years. This is what the FDA wants everybody to use. This has been the most durable approach. It's what we use for the 30-year-olds who have prolapse. But vaginal mesh, which we started using because using patients' own tissues was not terribly effective, comes with some risks. The interesting part is some of those risks aren't pertinent to women. So the biggest complaint that women have had is that there's painful intercourse in about 5% of women, which may or may not be clinically relevant to many women. So it's something that you sort of take with a grain of salt, and definitely something to talk to your healthcare provider about if you are interested or have questions. Now to our final topic, we're going to talk about recurrent urinary tract infections. There are a few different types of urinary tract infections in women. There's the premenopausal, the sort of before menopause, before low estrogen UTIs. There are the postmenopausal UTIs and the complicated urinary tract infections. So typical symptoms you might have heard for urinary infections, either you had them when you were younger, you currently have them now, perhaps you feel a little pressure, pain with urination, maybe you're running to the bathroom, you have a little incontinence. Most of the symptoms of a urinary tract infection that we think of are common in premenopausal women, so women who have estrogen, who are reproductive aged, who often have more infections after intercourse where there's just introduction of a lot of bacteria in the area. And in postmenopausal women, it's very interesting because this is the group that has the most urinary infections, and there are often no symptoms. Sometimes it's just a little incontinence and frequency. That's it. And then there's some vague symptoms. So somebody might say, I'm really tired lately, or I don't feel quite right. That's a urinary infection. That's more of a urinary infection in a postmenopausal woman than any other pain or pressure. Certainly if there's fever, real confusion, or retention, you just can't go to the bathroom because there's a lot of bacteria there. So what's the difference between pre- and postmenopausal women? It's the estrogen. Estrogen, again, I can't emphasize this enough, so many estrogen receptors in your body, and the lower genital urinary tract is no exception. So generally speaking, estrogen kills bacteria in the vagina. That's what it does. The vagina has more bacteria than any other place in the body. It's okay, you may have heard it before, it's like a self-cleaning oven. It takes care of itself. But a lot of that's because of estrogen. Estrogen allows for the growth of a certain bacteria called lactobacillus, which is acidic, and it kills bacteria. That's how it does it. Without estrogen, you don't have this lactobacilli, and the bacteria grow and grow and grow. And remember, we looked at that anatomy picture where the urethra is really close to the vagina. So it's not a very long distance for that bacteria to get into the urethra. And in a woman, a urethra is only 3 to 5 centimeters. In a man, it's 5 to 7. Much longer way to go to get into the bladder of a man, much shorter to get into the bladder of a woman. So treatment for recurrent urinary infections. In premenopausal women, we try and identify the source. Sometimes we give low-dose antibiotics for a long period of time. This scares a lot of women. Nobody wants to take antibiotics for a long time. But if you think about somebody being treated for recurrent infections and the powerful antibiotics they're taking over and over and over, taking a low dose for 6 months has been shown to actually very much prevent infections in both premenopausal and postmenopausal women. The other, in a postmenopausal woman, we can identify the source. For example, if somebody has prolapse and the bladder falling into the vagina, it can prevent the urine from coming out properly. And that bacteria can just grow and grow and grow in the bladder as the urine stays there. So there are a lot of causes for recurrent urinary infections that should be evaluated. The best treatment for recurrent UTIs in a postmenopausal woman is vaginal estrogen cream or vaginal estrogen preparation. It's the most common, the best. It's the only thing that's been FDA approved, and that's because the vaginal estrogen will kill off that bacteria. So how do you prevent a urinary tract infection? So a lot of people talk about hygiene. Well, you have to wipe from front to back, and after sex, you got to run to the bathroom, and you're not showering enough, and you're not bathing enough, and if you wear pads, you're not changing them enough. And guess what? The studies don't support any of it. None of it. We say it because it's easy to do. It's not so invasive, And why not? I mean, it sounds good, but it's never been supported. So I just take that with a grain of salt, because a lot of people who have recurrent infections think that something's dirty, but it's really not. A lot of people have heard of cranberry. Wow, I drink a lot of cranberry juice, doctor. I'm really trying to prevent those infections. Well, cranberry juice doesn't have a lot of the product that we're looking for when we look to prevent a urinary infection. What we're looking for is the cranberry extract, and that has been shown to actually prevent infection in a very specific organism in the bladder called E. coli. E. coli is the most common bacteria in a urinary tract infection, so it's pretty good odds that if you use cranberry extract, you might prevent some infections, but it's only been shown to be useful in E. coli. And what it does is it prevents the bacteria from sticking to the walls of the bladder. Estrogen, we talked about, is the best form to prevent a UTI, especially in a postmenopausal woman. And there are other supplements out there like D-mannose. D-mannose is a great supplement. For some women, it really works well. Again, it's only for E. coli, but E. coli have these receptors called monocylated receptors. And so the D-mannose attaches to that monocylated receptor so that it can't attach to the bladder. So it prevents that attachment directly to the bladder. And then those low-dose antibiotics that we were talking about. All right, so we are getting to the end here. Complicated UTIs, we kind of talked about that. If you have prolapse or another condition, you might have urinary infections for another cause, and that needs to be evaluated separately. And then I do see other conditions in the lower genital urinary tract, like female sexual dysfunction problems, inflammatory conditions of the bladder. There are a lot of bladder pain syndromes out there, like chronic interstitial cystitis. And I do a lot of fecal incontinence as well. So not just urinary, but also accidents with bowel movements. So finally, in the very last slide, female pelvic health really does involve an understanding of pelvic floor anatomy, because understanding that allows you to understand why the conditions exist. They really can negatively impact a woman's life, and these conditions are very common, but they really are treatable. We shouldn't feel embarrassed to discuss problems that are happening below the belt. They're out there. We should just get right to it. And that's it. Thanks so much.
Thank you, Kathy. That was great. If anyone has questions that they've written down and want to hand them across the aisle, we can collect them and go through some questions. So somebody asked whether a 90-year-old woman would benefit from the mesh sling.
So I operate in women well into their 100s, because if you're 90, the chances are you're pretty healthy. That's why you're living to 90. So I do see a lot of women in their 90s, and many women are candidates for surgery, both for prolapse and for a sling for incontinence. Absolutely.
Okay, so can you hear me? All right. This has three parts. Someone says that their labia bleeds on occasion due to thin skin and cannot use any hormone replacement due to a family history of breast cancer, and also some slight varicose veins in the area. Do they ever surgically remove the vein?
Okay, so this is actually a very important point. So there's a lot of bleeding that can happen because the tissues are thin, and that's really from the low estrogen. That's what we're talking about here. Interestingly, I just want to throw this out there. Vaginal estrogen is not oral estrogen. It does not give you a risk of heart disease and breast cancer like oral estrogen does. In the package insert, it is an estrogen product. It has to protect itself. So it does say, watch it if you have personal history of breast cancer or family history or heart disease. But there are many women in my practice who use vaginal estrogen and currently have a history of breast cancer personally. And that's a decision we make with the oncologist. There's very little absorption of estrogen into the bloodstream when you use it vaginally. So that's number one. So family history of breast cancer does not prevent a woman from using vaginal estrogen. But number two, this is from weak tissue. So it's hard to get the tissues strong if you're not using estrogen, which is really the thing that you need. But there are products out there. There are vaginal moisturizers, there's lubricants, there's Replens that you can use every 2 to 3 days. That's over the counter. There's Luvena, which is sort of a prebiotic. A lot of women say probiotics are very helpful. I think probiotics are great for good genital urinary health. So there are a lot of other things that you can do, but really the only thing that's going to benefit is estrogen. Now, in terms of varicosities or varicose veins in that area, that could be a reason why there's bleeding too. It's a little uncommon to remove them. That can be done. I don't do that personally, but there are vascular surgeons that can, because they're typically the ones that remove a lot of the big varicose veins, and they can make things bleed. So if that is an issue, it does deserve an evaluation, and they can be removed in certain circumstances.
So you touched on this with the probiotic, but the question was, if you're postmenopausal, can you take probiotic to combat not having estrogen?
I think they do two different things. So I think vaginal estrogen helps one or two issues. I think probiotics is good for general genitourinary health. And what I mean by that is everything sort of functioning normally. A lot of women have bladder symptoms when the bowels aren't working properly. A lot of things can feel exacerbated or do get exacerbated if there are problems with the bowel and bladder. So I think a probiotic is good generally for general infection prevention, not necessarily UTIs, but general sort of vaginal infection prevention, good bowel health, but it's different than estrogen.
So these are some questions about the mesh. What's the chance of scar tissue with mesh? Can you feel it when you're having sex? Would mesh ever have to be removed? Can you damage the urethra with mesh surgery where you lose continency?
I'm going to assume that the mesh is vaginal mesh for prolapse, or what the FDA was addressing. I can touch on both briefly, but I think that this is the one, the concerning mesh, the mesh that's out there that's concerning. I love that mesh in certain women. I think that mesh is fabulous. I still use it. I think it's great. In the right person with the right education. That mesh is... I already lost what was the question? I got so excited.
What's the chance of scar tissue?
Scar tissue can happen anywhere in the body with any type of procedure. So you're at risk for scar tissue no matter what you have anywhere in the body. Does scar tissue form preferentially in mesh? Not necessarily. We hope that your own tissues grow into it to give it support. So I wouldn't say that it necessarily has more scar tissue. As a gynecologist also, I can feel that on vaginal, I typically can feel some forms of vaginal mesh on gynecologic examination. It should not be felt by the partner during intercourse unless there's erosion of the graft, which is also a concern that the FDA had, or that mesh comes out through the vagina, and you can feel that on vaginal examination, or a partner can feel that during intercourse, and that's something that may not be symptomatic to a woman. Woman may not have any symptoms of that at all, but that can occur, and in that case, you can sometimes give a little bit of vaginal estrogen. It'll heal right over. But if it doesn't, it does need to be trimmed out and removed. So I actually think the biggest risk to that vaginal mesh is that you may have to go back to the operating room to trim a little bit of it out. Taking out the entire graft is extremely cumbersome and very challenging. This is one of the reasons that some urogynecologists don't like placing it at all, because it's hard. You have to be able to undo something if it's going to cause a problem, and it's very difficult to remove all the graft. But typically, if it does need to be removed, just a small part in that area. Oh, and it doesn't usually affect the urethra. So the sling that goes under the urethra with mesh should not affect the urethra in any way unless it heals too tight and it prevents you from urinating properly, or there's erosion inside the bladder, and that needs to be addressed. And that can be addressed actually very easily.
So someone asked, what is going on when there's a piece of skin hanging between the rectum and the vagina? Not painful. And the history is 4 vaginal deliveries.
Sure. So that can cause a lot of scarring. So whether or not there were episiotomies involved, big babies involved, a lot of pushing, a lot of, I was 10 centimeters dilated. They waited 3 hours before I had the baby. There can be some tearing that was involved. And so that is usually just excess tissue. Sometimes it is painful. If it is painful, it can be revised. If it's not painful, but it feels like it should be changed for cosmetic reasons, or you feel like there's loss of intimacy, that can be easily removed and revised and trimmed. It's sort of like revising any scar. So you just assume that was a scar in the area from a birth that can be revised in some fashion.
Is hysterectomy a treatment for uterine prolapse?
I love this question because it is not actually. This is like a very important point. I should have mentioned this. Thank you, whoever wrote that. Taking out the uterus when someone's uterus is falling down is only helpful to get it out of the way. You want to get it out of the way so that you can actually support the ligaments to the right place. So anybody that just takes out the uterus for uterine prolapse is not addressing the problem. And all that will happen is that the intestines that are right behind the uterus will take the place of the uterus, and they will push down into the vagina and cause that herniation as well. So we do take out the uterus typically when the uterus is falling out, but only to get it out of the way.
Do the usual abdominal floor exercises strengthen the pelvic muscles?
Abdominal exercises like sit-ups.
I think so.
So there are many ways in which you can engage your core. And I think sort of engaging your core is done in a number of different capacities, different exercise classes. Doing sit-ups in general isn't necessarily going to target that. There are some abdominal exercises that can help the core, which are those pelvic muscles. Some people do find that sort of Pilates helps, or exercises in which they are sort of geared more towards the core, but not always. But those are the muscles, not so much sit-ups, but the core.
Is it possible to make the bladder larger by drinking lots of water?
If you drink a lot of water, the bladder will get larger because it distends like a balloon. So you'll just have more fluid in there, and the balloon will get bigger, and the pressure should stay the same. It's not going to make the bladder larger in terms of storage. It's just going to make you have to go to the bathroom faster.
Can you discuss the trend among young women who want a C-section to avoid pelvic floor problems? Is there a benefit of that over vaginal delivery?
Yeah, without getting too personal, I've had 3 C-sections, but I was very happy that with my first, it was because my son was breech, and I had to, and then I had to for other reasons with the second, and then you have to with the third. So I didn't have to make that decision, and I, as a urogynecologist, would have been faced with a very difficult decision. About 50% of urogynecologists will have a C-section to try and prevent pelvic floor disorders, but I see plenty of women in my office who've just had C-sections or no kids. So that tells you right there that the risk factors are not just vaginal delivery. It does protect the pelvic floor a little bit. You don't get the additional damage, let's say, of a vaginal delivery, but it's not 100% protective to have a C-section. And women are desiring C-sections for a lot of other reasons also. They don't want to distort the pelvic floor. They want to have a scheduled section for whatever reason, for either work reason or family lifestyle reason. There are a lot of reasons why people have C-sections, scheduled C-sections, but you don't necessarily prevent damage to the pelvic floor. Pregnancy will do it.
Do birth control pills contribute to urinary tract infection in young women?
It's an interesting question. I guess because of the hormones involved in birth control pills, no, they do not. That should not be a reason why women are maybe they're having more sex because they're using birth control pills, and that's the reason why, but not because the birth control pill itself is doing it.
Someone asked, is it unhealthy, or are you at risk for bladder problems if you tend to put off going to the bathroom because your day is too busy, you're driving a long distance, etc.?
Yes, I think women that hold it too long for the majority of their lives are at risk for damaging their bladders a little bit. The muscle itself can sort of get overtired over time. So, in some respect, you don't want to hold it all day, but then it gets to the point where now you're holding it and you're driving and you see your house and then you leak, or the key is in the door and you leak. Everybody thinks it's in their head. It's not. That's the reflex that started. But I think if you're holding it too long because, you're running around and you're a teacher or whatever the profession or lifestyle might be, you do want to try and go to the bathroom in a timely fashion, but you also want to tell your body that you can hold it a little bit. So you should be able to wait 2 to 3 hours before going to the bathroom.
Do men have to do Kegel exercises? Would it help them?
That's a great question. So right now, I'm just letting you all know I'm not an expert in men's health. So take this with a grain of salt. Men's anatomy is a little bit different. Their reason for having an overactive bladder is different. They can do Kegel exercises. It is not going to give them the support that it gives a woman because of the anatomical differences. So the Kegel exercises aren't quite as effective in a man as they are in a woman.
Does a short labor prevent the problem?
No, I mean, it doesn't. So we know pregnancy can do it. Oh, asthmatics, chronic coughing, bronchitis. I mean, anything where you're really pushing on that pelvic floor for a long time is going to give you some issues, potentially. So having a short labor, again, it might prevent more extensive damage, but it's certainly not going to prevent the issue altogether.
Does anyone have any other questions that they wanted to ask?
Yes.
If you're getting up, say, 3 times during the night to go to the bathroom, is there any way of reducing that by not drinking right before you go to bed or?
Right, so a lot of this urgency incontinence, most women don't have all the symptoms, so they may be fine during the day and all their problems are at night. The ICS, the International Continence Society, if you can believe one exists, used to say, you know, they used to have very strict criteria, but I hope no one's making fun of that, by the way. I really adhere to that. No, I'm just kidding. The International Continence Society had really strict terms for what was too much in terms of waking up at night and waking up during the day. And now, like bowel function, most people just say whatever is more than what's usual for you. So if waking up once at night has been usual for you your entire life, we think that that's maybe okay. Waking up 3 times is a little bit more excessive, especially if you can't get back to bed. It really can affect your day. There are certainly things you can do. Obviously, minimizing what you're drinking at night really helps. Some women come in my office and they'll say, well, I really need that glass of wine before bed. And I'll say, well, I mean, we need to think about it a little bit, but that's fine. If you want your glass of wine, have the glass of wine, and maybe we can try other things. But certainly that's the first place to start, is to minimize. A lot of people say stop drinking after 6 p.m., which is challenging, but don't have that cup of tea at night. If you're taking medications at night, try not to drink it with a full glass of water. So there are certain behavioral modifications, we call them, and I'm glad you raised that. That is something that we talk about. But then you might just need a little medication to retrain your bladder to think a little bit differently so that you can get through the night and then you get off the medication and then you're better. So medication is not intended to be lifelong either.
Yes.
I wonder if I am correct in the assumption that improper breathing will be very detrimental to improper pressure put on internal organs during physical exercise, such as Pilates, such as yoga. And of course, the opposite would be that proper breathing would be beneficial. I can very well see that if you hold in your breath while you're straining, that you're putting undue pressure onto your internal organs and the supportive network, abdominal network, such as ligaments, tissue, etc.
You raise a very interesting point. I mean, I think proper breathing is good for a number of different reasons. I think it's good for control. I think it's good for management of, the coordination of musculature in the body. And certainly if you feel as though you're not coordinated in your movements, whether it's from taking a deep breath or not having enough air or having a pulmonary condition that prevents you from breathing properly, can certainly have some manifestations, maybe not direct anatomical problems, like direct damage to pelvic floor, for example, but indirectly from maybe lack of control and lack of coordinated movements. Sure. Yeah, certainly.
All right, we'll take one more question and then we're going to wrap it up.
Are there any vitamins or minerals, and do you recommend phosphatidylcholine daily to prevent?
All right, so here's the deal. I love integrative health. I think it's really important. I was not trained in it. So I'm so happy to send women to the Integrative Medicine Center at Stanford. I know that a lot of women use pumpkin seed oil. Pumpkin seed oil has been very beneficial in urinary health. The brand Azo actually has marketed their non-medication, non-pharmacologic treatment for urgency incontinence. It has pumpkin seed oil in it. So I know that's a big one. Beyond that, I don't know, but I love to defer to people that know a little bit more about it. Acupuncture's been helpful in terms of reducing anxiety, going to the bathroom frequently, and when you're trying to change the behavior a little bit. So there's a lot out there. Hypnosis has helped women. I can send people to the right place, but I don't personally do it. But I do value it.
Thank you, Dr. Sandhu.
Yep. Thank you.
Just a reminder that the session for next week is Dr. Jacqueline Brewer speaking on ear, nose, and throat disorders. Oh, one last question, if I can read it.
Do you need me to read?
600,000 women in the U.S. have hysterectomy. Are these women more prone to urinary incontinence, vaginal prolapse down the road?
Yes, they are. There are about 15% of women who have hysterectomies end up having prolapse after. So at the time of hysterectomy, we often bring tissues together to try and prevent that from occurring.
Thank you. All right.
practice